We're here at the 7th Conference on Pathogenesis and Treatment and Prevention for the IAS in Kuala Lumpur. And we're here with Adeeba Kamarulzaman. I'm going to say it again. Kamarulzaman. And my name's hard to say too. But we really appreciate you taking the time as the co-chair to come and talk to us a little bit about what you've done in the past and your role as the co-chair in the conference. And so if you would, to start off by telling us a little bit about how you got into the field of HIV. I think there's a robust history there.
Yeah. Okay, so I trained in internal medicine and infectious diseases in Melbourne, Australia. At the time when HIV was a death sentence, and I worked with some very inspiring people in Melbourne who kind of got me really interested in infectious diseases in general.
Your mentors?
My mentors, and HIV in particular. As part of my training, I spent 2 years at the Fairfield Infectious Diseases Hospital, which was a beautiful hospital that really went back to the old I guess the old principles of medicine, patients come first, and we got to know the patients really well and their families and all that, and all that left a very big impression on me. And then I returned to Malaysia in 1997. At the time, HIV was very kind of under the radar in Malaysia, but thanks to Marina Mahathir, who was one of the chairs this morning, she did manage to put HIV on the map in Malaysia, despite it, being difficult and controversial and so forth. I worked I still do, at the University of Malaya Hospital, and at the time I guess concentrated more on establishing a treatment center, both for general infectious disease as well as HIV, and establish clinics and start getting treatment in and so forth, and establish wards. But as the years went by, I just thought it was crazy that we were seeing so many patients who were infected through injecting drug use. And I guess that also reflects my training and my experience in Australia, where I hardly saw anyone there who contracted HIV from their drug use. And it's not that there were no drug users in Australia, it's just the harm reduction programs were established so early and so successfully, and I thought, something needed to be done. It was just crazy. Seeing all these young men come in, with end-stage disease when something really could be done. So I have to thank the NIH really, that kind of got me started on the prevention route, because I applied for a CIPRA grant, the International Program for Research in AIDS that NIH had. Unfortunately, that's been discontinued, and I managed to get a small R03 grant, and as part of that did a situational analysis and used that data to kind of advocate, but also to bring, we had a meeting, and I still remember this sort of seminal meeting, which for the first time brought together people working in drugs and people working in HIV. And as a result of that one-day meeting, we decided to form a working group to kind of focus and seriously work on the issue. I remember, and I had my colleagues, a few colleagues and mentors from Australia who were here to help facilitate the workshops and so forth, and we armed it out for hours on what we should call ourselves, the harm reduction working group, because it was like, oh my God, we're going to get the wall up as soon as we call ourselves a harm reduction working group. But we thought, what the heck, let's call it what it is. And we knocked on doors, we saw parliamentarians, we approached different agencies that were involved in drugs, and finally we managed to get a meeting with the then Prime Minister and the Deputy Prime Minister, and got our.
Did you have many allies on your side from your colleagues?
We had important allies. I think we didn't have many, but we had
the right ones.
The right ones, consisting of lawyers and ex-policemen and people who had different networks. So that was very, very helpful, and of course other academics and doctors. Yeah.
What did you take away from the meeting yesterday with the high-level discussion that we had?
I tell you, I was very pleased to hear Minister Nancy Shukri say what she did, and I think she meant it, and it would be very, very important for us to follow up on that. I mean, Malaysia really is shifting, particularly with the drugs agency people providing, the cure and care, voluntary treatment, and that, we have to acknowledge the leadership of the Director General of the drugs agencies to kind of really work towards closing down the detention centres and providing voluntary evidence-based treatment. And so I think there are moves in all the different agencies. So what we really need to do is now to integrate and consolidate and look at where the existing barriers are, and to move this further.
Okay. So what are the things that jump out at you that you're really most interested in at the conference, that you're going to be hoping to see?
Well, I think how to implement the new
WHO.
Yeah, so I was part of the I was the chair of the program section of that, and acutely aware of the difficulties, particularly in key affected populations, particularly in people who use drugs, in terms of integrating against drug substitution treatment and TB and ARVs and so forth. So I think we really need to sit down and see how we best do this. Taking some of the lessons learned from Cambodia, they have a slightly different epidemic in terms of which key affected populations affected, but I think there are lots of lessons to be learned from Dr. Min Chivun's presentation this morning. And really, I think my next step, apart from pushing the drug policy agenda forward in Malaysia, is also to address something that's really not been addressed at all, which is HIV, Hep C co-infection. There's so much advances in the world of HCV treatment that I think we need to figure out how to.
It seems like that's going to be, it's just on the horizon for coming out with the new treatments, which are going to be much more effective and less costly and more
less
quickly
side effects and so forth. Yeah.
So down the line, I'm really, I guess the programs that you're doing now are mostly focused at, that you work on is mostly HIV. Is that true?
Yes. Yeah.
So are you working in prevention a lot, or are you mostly working at treatment?
No, we're working in prisons with prevention, mostly secondary prevention in HIV infected prisoners who are former or current drug users who. So we have, again, an NIH-funded project that we're collaborating with colleagues from Yale to give them methadone before release and testing that against, with or without specific behavioral counseling and intervention, and to see if that could reduce the rate of relapse to heroin use and as a primary endpoint, and rates of incarceration and so forth.
Going back to the World Health Association guidelines, do you feel that some of the people are concerned that if the guidelines are in place just as far as getting people under 500 being treated, that the treatments for that country, or that what they're using or what they're operationally using is just an old first-line treatment, might not be the best way to go in such early treatment. So, it may be that they should scale up slowly when they get access to the more tolerable drugs, that would be when they'd be thinking more about it is a guideline.
It is a guideline, and as Stefano Vella stressed in the session this morning at 11, I think the priority remains to get people who are under 350 to go on treatment, and
get more of them on treatment.
Yeah. So I think that obviously remains a priority, but also to address the currently toxic combinations that many countries are using because of cost. Stavudine-based treatment is also a priority. Yeah.
Okay. Well, you've helped me a great deal with getting a sense of what it is here in your country that you're dealing with, and I think that you're not untypical of a country which is developing. And I think it's really a great thing you have time to speak with me about it.
Thank you.
Okay.
Yeah. Thank you. Thank you very much.